Dr. Ellen Perrin, who has done some incredibly important work in this area. She is a developmental behavioral pediatrician at Floating Hospital for Children in Tufts Medical Center in Boston. Her work focuses on maximizing the potential of the primary care context and relationships to support family and child development.
Thank you, Denny and David, for setting me up here. You're a hard act to follow, but I'll do my best. I'm hoping to give you some examples of parenting support and education programs in pediatric settings that have been proven to be effective in different ways. They're very different examples. So first, just to talk about why pediatrics, and again, David kind of said this already, but pediatricians are the primary professional contact for toddlers. Parents have frequent and regular contact with their pediatrician. It's a familiar and trusted context with a preventive focus. It is, in fact, non-pathologizing and has very easy access. So in many ways, I'm just going to agree with David's comment that this is a natural for, as a vocation or as a context for family-focused preventive activities. So I'm going to talk about two examples. One was called Advanced Parenting Education in Pediatrics, and it was done in Massachusetts, and it was based on the Incredible Years program, which is one of the programs David was mentioning that has a lot of research evidence behind it. And the other one is the Triple P Positive Parenting Program Initiative, which is in Washington State. That's a very different kind of program, not a research program yet, but has some very interesting lessons that I think will be worth our talking about a little bit. So both of those programs have solid research evidence of effectiveness. They have been shown to improve parental attachment and bonding with infants all the way up through school-age children. Both of those programs cover that wide range of ages of children. They have demonstrated reduced child maltreatment and child behavior problems, and have shown that parents are less stressed and happier as parents and more successful, feel more successful. But typically, they are provided in mental health and community settings, and they're provided mostly for parents of children between 5 and 12 who have disruptive behavior problems. The program that I'm going to describe at greatest length, because I know it the best, was called Advanced Parenting Education in Pediatrics. And it's a program that was funded by NIMH, and it was an intervention for toddlers. It was offered to parents who identified their children as being at risk for disruptive behavior problems, and it was carried out in groups of 6 to 12 parents, but based in a pediatric practice. So rather than in a mental health center or a community setting, it was located in a pediatric practice and led by a pediatric staff member who was trained and helped along by a research staff member, but parents saw the pediatric staff member as kind of their main contact. We carried out this study in 4 federally qualified health centers and 7 suburban practices, and identified families as being eligible if they acknowledged or reported disruptive behavior. How about this? Is that better?
Yes.
Okay, sorry. So the pediatricians who were involved in this project asked parents at the beginning of their 2- and 3-year-old well child visit to fill out a screening form which indicated whether they had any worries about the disruptive behavior of their 2- or 3-year-old children, and if they did, they then became eligible for this 10-week parent education group that was happening, as I said, in the pediatric practice. So We used the modification of the Incredible Years curriculum, which normally is a 16 to 20 week program. We did it as a 10-week program. We encouraged both parents to attend and induced them with, the groups were always in the early evening, so we offered them dinner, a small dinner. But from the beginning, we wanted to make sure that this program lasted beyond the end of the grant. So we did a couple of things. One was we trained 2 of the staff members in every pediatric office, and the staff members who signed up to be trained were a whole variety of different staff. But we didn't offer childcare or transportation because we figured that was never going to happen in a pediatric office, and so we wanted this to be as much like the real world as possible. The project was designed as a kind of the gold standard kind of research, as a randomized controlled trial in which parents who were eligible either got asked to be in the group right now or a year later. And then those were compared, and I'm going to show you some of the results of that comparison. And we did a number of things to identify how we were doing immediately before we started the group, immediately after, and then 6 months and 12 months after. So we have a relatively long-term view of whether what we did was helpful to them. So as David mentioned, we had almost 42% of the people who were eligible enrolled. We were actually a little disappointed by that, but it's true that in contrast to most other studies, that's actually a lot. We had hoped that we would have more like 80%. That's because we have high expectations. At any rate, the population that enrolled in this project were very diverse in terms of race, ethnicity, and socioeconomic status. Children were between their 2nd and 4th birthday. As I mentioned, this project was geared to toddlers, and 2/3 of them were male, which is very standard for any kind of disruptive behavior research. So you don't need to remember this, but I just want to tell you what we did to investigate the effectiveness of this, because I'm going to show you some pictures in a minute. So in order for you to understand the pictures, we did 3 things. We asked parents to report on their children's behavior using a standard report form called the Early Childhood Behavior Inventory. We asked parents to report on their own how they would respond to certain vignettes and examples that we gave them of parenting, and the parenting, so that's also a standardized questionnaire, and in that form, higher scores indicate more harsh parenting and harsh discipline styles. And then we also did something which is much harder to do, and but really important, which was we actually observed the child and the parent together. And we coded, and actually we didn't code, we had someone else, independent person, code what the interactions were like between the parent and the child. And here again, the more restrictive and authoritarian kinds of behavior that we noted gave the person a higher score on this. So this is what the wait, you don't have to remember the numbers, but this is what the wait list group, so the group that wasn't getting any intervention, looked like in terms of the child's, the number and the severity of the child's behavior, disruptive behaviors, and this is what the study group looked like. And both at the 6-month, I guess I could, I don't know how to do this. Well, both at the 6-month point, 6 months after the intervention and a year after the intervention, those differences are very much statistically significant. On the parenting scale, a little more jaggedy line, but still the research group, the intervention group, had reported considerably lower amounts of harsh discipline styles compared to the waitlist group. And in the videotaped observations, those two depend on parents' reports. The videotape observations, which don't depend on parents' reports, we still found some similar difference, although for reasons that we've never been able to figure out, the waitlist group parents reported or demonstrated less harsh parenting in the videotaped observation at the end of the study than in the beginning. So the difference isn't quite so significant, but it still follows the same pattern. We also got just on a qualitative level, we got just amazing feedback from parents and from pediatricians. So parents said things like, this group has been like the manual everyone talks about not getting. And in every single group, parents didn't want it to end. The program lasted for 10 weeks, and everybody begged us to go for 11 weeks or 12 weeks. We didn't because it was a research study, but it was a pretty consistent message. Parents said things like, this group has changed my life. I deal with my children in a totally different way. Pediatricians also were very enthusiastic. They noted that this program had been such a big help to parents and therefore to them. They said that they wanted these groups to be a regular part of what we offer at the health center, and talked about how many patients and parents would benefit from a program like this. We had universal enthusiasm from both parents and pediatricians. So let's talk about cost. So the startup costs are hefty. And that is true for Incredible Years, it's true for Triple P, it's true for most of the programs that Dr. Hawkins mentioned. But thinking about doing this in a primary care practice, you only have to do that. You have to pay for that once. And once you have those manuals and training materials, you don't have to add that into the per session cost. So we did some calculations about over and above the startup costs, what would it cost? Well, the sort of bare bones model in doing Incredible Years, doing the program that I just described to you, is only a little bit over a copay. It's about $26 or $28 per session, per parent per session. That's not feeding them dinner, and not giving them a parenting education book or providing childcare. So it's really a bare bones version, but again, this is not a lot of money. If you do it the right way, so you have 2 leaders, you provide food, you give them a book, and you provide childcare, obviously that will increase the number of families that can actually partake in this. And then you're talking about closer to $100 per session. It's still not a lot of money, but obviously it's more. One comment about the 2 leaders. These groups tend to become quite emotionally intense, so it is actually a lot better if it can be done with 2 leaders. It's a much more effective group because if it's 6 to 12 parents and emotional mental health issues and the parents come up and serious disagreements among people, it's hard to manage. So even though I'm presenting you this $26 per person per session bare bones cost, it wouldn't be what I would recommend. So just to summarize this particular project, we did the project in 11 urban and suburban practices, had a very large and diverse sample. This was, in the terms that Dr. Hawkins was talking about, this was indicated prevention because parents did a screening test first, and if they reported disruptive behavior, then they were included. We trained the practice staff, We trained the practice staff to co-lead the groups and implemented an evidence-based program and did follow up a year later and documented improvement. But let me say a word about the actual sustainability. I said that we thought about this from the beginning. Initially, 4 of the 11 practices continued to run groups, so not even half. 2 of those charged families for the 10-week program, and a year later, only 2 of them maintained groups, and both charged families, and 2 years after that, none of the practices continued to run the groups. So we were successful in certain ways and unsuccessful in other ways. And that's part of the motivation for me to keep moving on to solve some of the problems that got in the way here. So now I'm going to change gears and tell you about a very different program in Washington State, which is led by Dr. Kearns, who couldn't be here today, so I'm reporting on her project. But the project there, they train primary care providers to deliver counseling through a program called Triple P. And they train physicians, nurse practitioners, and physician's assistants to do this. Training is 1 to 4 training sessions, and that results in certification by Triple P that says that they're adequate to provide these programs. This has been done in 3 rural communities and 1 urban community in Washington State, and the training has succeeded in reports of increased skill and increased confidence. And once they get that certification, they are allowed to provide counseling in their office for up to 3 visits that are paid by Washington Medicaid without a diagnosis. These are some of the barriers that we've encountered in other places. And they've also developed referral protocols in the community if further support is needed. So I know I only have a couple more minutes, so I'm going to go quickly and say that there's plenty of evidence that parent education is effective. We really don't need to discuss that anymore. Parents do better, children do better, parent-child interactions are better, and so forth. You've heard this from other people. And as both Dr. Hawkins and I have said, the primary care context is in many ways a perfect site for this to happen. But can we do it? Is it feasible? Well, it fits with the growing priorities within pediatrics, the notion of parenting support and education as being an integral part of the medical home model. Evidence-based programs are readily available. Parents love it, pediatricians love it. Space is usually not a problem. It doesn't really cost that much. So why is it not happening? And so now we get to what are the barriers and what can we do about it. So right on top of the list are billing constraints, which lead to limited sustainability. And there are 2 big ones. One is that it's very difficult to bill and be paid if the child doesn't have a diagnosis. So if you're talking about prevention, the child doesn't have a diagnosis. And that's been a big barrier. Another thing is that while for individual interactions between the physician and a parent, the child doesn't have to be present for the bill to be submitted and the pediatrician to be paid. But for groups, there's no way to bill and be paid for that activity if the child isn't present. So a parenting group like the one I described in the Massachusetts program, we could not get any way of the pediatrician or the nurse practitioner or whoever being paid. The second thing is just that this does require some administrative time, so that's another cost. We did add that into our costs, but that's one of the things that has to be thought of. And I think probably maybe the most important, or at least up there with the most important issues, is that pediatric offices more and more are realizing that they need to have a team. They need to have a team that integrates physical and behavioral health, which means that they need to have some staff member in their office that is sophisticated in behavioral and mental health care. And that's been a very hard innovation to fund. So that's, I think, a big reason why this kind of activity isn't happening. So I think the slide basically says the same thing. I think successful parenting programs really require training for pediatricians, on-site mental health clinical resources, and administrative resources. It also will require universal screening, which some states have done better than others, and I'm not going to digress and talk about that now, but universal screening would allow us to triage which children and families would be best benefited by programs like this. And again, a payment system that really rewarded preventive services would be pretty important. So just in summary, nothing of this is new, but parenting is hard but critical to children's development, and parenting skills can be learned. It's not, as Dr. Hawkins said, it's not necessarily intuitive. Pediatricians are eager to help with this, and children and families really need us. So I think we can do these things. These are not unsurmountable, and I'm hoping this will be the first step. Thank you.